absolutely. Everybody good to go to get started again? All right, cool. Again, just a reminder, if you haven't done yet, as we start the second hour online, remember to put your name and EMT number on the chat again so that I know that you're still here. And then I will transfer you to the roster. Yes. Okay. Has everybody gotten to the second hour roster? If you haven't, it's up here. Okay, Doc?
Yeah,
Are
I
you ready?
signed both. Yeah.
I'm not a smart man, but
And I'll have you sign
Yeah, they
it.
have two different numbers.
I'm just curious what my guys.
Yeah, just as a matter of housekeeping, you guys, I think, let's see, it's July, right? So, I think I have two more M&Ms that I wanted to do September and November. Yeah, so I hope you guys don't mind doing a few more of these. Because when I first came here, we were only doing what, 2 or 3 a year?
I was a little worried when you had this.
Yeah, right. Because our last one was April, wasn't it? March? Yeah.
I missed out.
Yeah. Yes. Because I figure if we do them more frequently, then if you miss 1 or 2, you can still come later and get the credits you need, because everybody gets scrambling. If we only have 2 or 3 of these a year, you're scrambling. Yeah.
now that the show is closed, those M&M runs are done.
Yeah, that's right. Yeah, if you guys know your colleagues over that way, they're more than welcome to come. Get the credits. Okay. So I picked some random cases for you guys tonight just to go over. A lot of them have to do with the topic. What I hope to do each time is do the didactic in the first hour, and then the runs we review will apply into that, and then we can see the A's and the nays. It just reinforces what we talked about in the first hour. So here we go. This is a 96-year-old male. He is calling his family's calling 911 in the afternoon. He is actually, this is classic. He's sitting on the commode, but arousable only to painful stimuli. And unfortunately, he has copious amounts of blood on him and in the bowl. So we already know what the problem is. Now we've got to think outside the box because our brains are going to GI bleed. Could this guy have other things going on? And that's part of the assessment. You ask the responders here, ask the family, when was he last normal? And that was 1930 last night. And this is around, this is around 15 in the morning. So we go from night to morning and he's doing this. Interesting. He may have been bleeding all night, who knows? His only medical problems for being 96 is hypertension. Unusual. So here's this guy who is probably pretty healthy for his age with only hypertension. Now very, very loosely responsive with massive GI bleeding. Pretty interesting. Exam reveals a blood pressure of 110/65, which is a little on the low normal side, but not too bad. Heart rate of 62 and regular. His respiratory rate is 14. Blood glucose is 122. He's 90% on room air. So in answer to Eric's question, would you put him on oxygen? At 90%. Right, I would. So here he goes. GCS is calculated at 11. And the responders describe his exam as slurred speech, facial droop. I can't remember what side it might be later on the report. Pupils equal reactive, no drift. CSM is 4 with weakness on the right side. Facial droop is on the right side as well. Airways patent, his respiratory rate normal, unlabored, lungs clear, oxygen, like I told you, 90%. The rest of his exam looks good here. ECG shows normal sinus rhythm, no ectopy, with the exception of a rare PVC. No STT wave changes. I ignored the 3rd-degree block. I'm just kidding. That's not in here. Just want to make you smile a little bit. IV is started with 20 gauge left AC, good move. Patient's placed on 3 liters per nasal cannula. Not bad. 2 to 4 is okay. The amount of flow on oxygen is not the number, but the reflection of the pulse ox. So if you can get the pulse ox at 94 or up, regardless of what the flow is, that's great. You guys know better than I that once you get up to 6 nasal cannula or higher, it's probably not going to make a big difference. If you're blowing 8 or 10 in the nose, there's no way all that's going to go in there. So you have to change it to a simple mask usually. Or dry their nose out and get a nose bit. I was known to do that once when I was a third-year medical student. I'll tell them myself. I just thought it was good to turn the oxygen up on a patient, and when we came in the room to do rounds with my attending, he got a little bit of breathing in there. Why is his oxygen up at 10 on the wall? I kind of got my skin peeled for that. I learned that the hard way. But what do you know when you're a third year medical student? So what happens to this guy? Wisely enough, this guy has all the signs and symptoms that he may need to go to tertiary care, right? Is he in hemorrhagic shock with a blood pressure of 110? Nope. Could he go into hemorrhagic shock? Yes. He has active GI bleeding. His heart rate is 62. His blood pressure is 110 over 65. The folks on board did repeat vitals in 9 minutes. I thought that was great. The vitals are largely unchanged. His mental status is largely unchanged. His sugar wasn't rechecked because it was normal at 122. His oxygenation is now 95%. That's pretty good. Everything is looking pretty stable. They calculated a fast ED of 4. And as we alluded to last session, 4 or more probably should go to tertiary care. Good move on their part. Sure enough, this patient goes to UMass. Now, with my ability to get into Epic on a limited basis, I was able to find out that this patient did indeed show up at UMass. They treated him for a massive GI bleed. He got 1 unit of PRBCs. It was thought to be more syncopal, interesting enough, than anything else secondary to his GI bleed. No neurological deficits, stroke workup benign. Patient did not wish to undergo a colonoscopy because he couldn't tolerate the threat, interesting enough. So they treated him with a PPI. I don't know, they didn't say that it was lansoprazole or whatever, but anyway, he was stabilized and actually discharged. Pretty cool. So this is a good example of what looked like it could be a stroke and actually scored a fast ED of 4 or more, but it was another etiology behind his stroke-like symptoms. Okay, so very good assessment on the medic's part. I couldn't see much in this run sheet that made me think we should do some correction or just bumping the head there. So when in doubt, you guys can always call us and radio in. A lot of the times these tertiary transports are done automatically. You see the protocol, but when in doubt, you can always call and say, Dan, I've got this. The vital signs are this. What do you think? Okay. So, any questions on that one? Okay. Pretty straightforward. This is, let me see. Oh, this is 62 though. So here we go. A call goes out. You respond to find a conscious, alert 62-year-old male. He's in semi-Fowler's position on the ambulance cart because rescue truck got there first. And just general illness, so that's all you know. You walk in there, and this patient is obviously left-sided hemiplegic. First responders notice this, and that's why they have them up to maintain a good airway. And the left side is hemiplegic. This includes left arm and leg. That's why they called ALS. Sister noticed him just being a little bit altered and with this weakness. The only known history of this guy is hypoglycemia. Okay, red flag, right? Very good of the writer to put that in history. States they obtained patient's FSBS, and it was 153. Does that rule out hypoglycemia? Of course. So that's a good treatment by first responders. Patient found with clear speech, but has apparent expressive aphasia. Good. good narrative here. Patient is noticed to have profound left-sided weakness, inability to look left. I love that. You're telling me that there's inattentiveness. It helps me place where is this stroke happening. He's got left hemiparesis, expressive aphasia, and neglect on the left side. Where do you think the stroke is? It's on the right. That's right. It's probably an MCA lesion, right? And the more proximal the lesion, the more deficits the patient will have, because the bigger portion of the vessel ends up branching off more. So it's like chopping the trunk of the tree, the whole tree falls. But if you're up in the branches and you're just chopping off the branches, the tree survives, right? So same idea with the stroke. Positive sensory extinction to left side of his body shows no gross trauma. Very good point, because trauma can certainly cause this if they have a head bleed. So if you see a big cephalohematoma on the right side, it might make you think, oh, this is trauma. Or the patient's cap is clinging to the right side. So this patient sounds like, looks like, smells like stroke. Now here's the other weird part. He was found, the first responders tell you, he was found naked on his hands and knees on the floor. Now, does that imply that this patient had good mental status? Probably not, unless he's really into something weird. So we're not sure how long the patient had been like this or where he'd been. He didn't show any gross trauma, so we've got him in a gown or whatever they did. No recollection of eating today. IV is initiated 18 gauge right AC. Probably not a bad idea to put a big IV in there. Patient has sinus on the monitor without XP. That's very encouraging, because cardiogenic problems can cause stroke. 12 lead EKG was non-diagnostic. SpO2 was, all I didn't do was that was okay. And let's see what else to tell you. He seems uncomfortable. Recumbent, so they put him in a right lateral position. That's an interesting point. A lot of patients who have a stroke, when you place them on the affected side, they are hypersensitive or hyper-aesthetic on that side, and it hurts. So don't be weirded out by that. That's kind of a normal in stroke patients. Because the nerve interpretation to the brain is way off, these patients will often hurt when you put them on that side. So you put them on the unaffected side, they do better. Maintain a good airway. Okay? Let me give you a vital sign. As you can see, I was not thinking of writing this down. Here we go. Heart rate's 82, blood pressure is 139/83, respiratory rate at 22. Had to get my, wouldn't worry about it. 96 to 97 on one there, pretty darn good. Fast EV was 4. GCS around 15 with confusion. So remember, GCS doesn't tell us about the mental status so much as it tells us about their awakeness. So there's a little bit of difference there. So when you guys are using both a fast EV exam for stroke as well as the GCS, they complement each other. Very, very good. Okay. For kicks and giggles, you know, everybody knows where the GCS was first described, developed, and validated. What city in Europe? Glasgow, Scotland. Yeah. When my wife and I went, yeah, we went over there and we actually saw the university where that was developed. Felt really cool. That's good. So, in a wise move, the paramedic transports this patient directly to tertiary care. Awesome move. At tertiary care, UMass, they do a CT and CT angiogram, which happen to be normal. Wow. So no bleed, no tumor, and no blood vessel problem, even though this patient is densely hemiparetic with abnormalities of vision on that left side. So what else could this be now? You guys know? Just random guesses. No answer is incorrect. It's still could be a stroke that we're not seeing, perhaps weird. Maybe the blood flow was compromised for some reason. Could he have had a dysrhythmia that he came out of and no one detected it? That's always possible. Could it be a seizure? What do you think? He was post-ictal and just really weird. That's very possible. Yeah. Could it be toxicologic? Could he have taken, something weird? Was he chewing on mushrooms? Was he overdosing on lithium? Or is he ... So it could be what we call toxicologic encephalopathy. It's a big two words there. If you get encephalopathy in a Scrabble game, guarantee you will. And I'm sure you'll get a triple the letter. Okay? So it could be toxic encephalopathy. Also could be an infectious problem, right? How do we know this guy doesn't have meningitis or encephalitis? Making it really weird, right? So sure enough, they do an EEG in this guy and they find focal changes in the right hemisphere. And he had left-sided symptoms. So all of a sudden we're seeing some seizure activity on the right side of his brain. Are you going to close the door? We've got our diagnosis. We're all done. Not quite. We put the patient on Keppra in the hospital there, and Keppra made this guy really agitated, combative. I mean, talking 4-point restraint combative, which can happen with Keppra. It's a side effect. Interestingly enough, they put this guy on Depakote, which is valproic acid, and sure enough, his mood gets better. His whole condition just changed, and it became his normal self again. Interesting. His white count was slightly elevated. We did an LP. The LP showed a few white cells, but nothing succinct. Doctors thought it might be a viral encephalitis perchance versus seizure. Which came first? The encephalitis causing the seizure, or the seizure that just happened that there were a few white cells in there? We may never know. But anyway, they discontinued all the antibiotics they put them on in the first place because often in this case scenario, we think the worst and work backwards. Someone that's really weirded out, stroke-like, and we ruled out a hemorrhage or a thrombotic stroke. The next thing we think about is this infectious. So they put them on ampicillin, vancomycin, and Rosuva. That's the triad of the drugs we use if a patient has acute meningitis. Not so in the child, but on the adult. Drug of choice on pediatric meningitis, just for kicks and giggles, is ampicillin. Ampicillin and ceftriaxone. So this guy recovered rather well. Discharged on Depakote, went to rehab, and from there I don't know. 62-year-old man found naked on his hands and knees. Turned out to be a seizure. Pretty cool. So there's a classic example of what looked like, smelled like, sounded like a stroke. Turned out to be something very, very weird, right? Would you treat it any differently in the field? No. And did the medics and the first responders treat this correctly? I think so. I didn't see any red flags here either. In fact, I looked a little hard, but I didn't find any charts that really needed like red flag or hand slapping or shame on you. You should have taken the UMass. So you guys are doing a good job out there. Keep up the good work. Either that or you're not printing line sheets and throwing them in the waste can. Dan will never see that. No, just kidding. Okay, third case. 61-year-old female. She is found completely oriented in her bed. Her partner tells her, or tells you, that she was last seen normal around 11 o'clock in the morning. And your response on this is, well, this is early afternoon. Oh, I'm sorry, 12:30. So last seen normal at 11. You're there at 12:30. So this is what, an hour and a half? She's unable to get off the toilet. Bathrooms are dangerous places. Or use her left side of back foot. Where's your brain go? Your brain went where mine went. It's stroke. So she obviously went to the bathroom. Kind of okay, we're assuming, right? She got there. But now she can't use her left side. Her partner assisted her to the bed because that's when we found her. So that means that she can walk with a little assistance. She has a history of an MI with 3-vessel bypass surgery. Red flag there, right? And that happened 8 months ago. And when that happened 8 months ago, here's another piece. That's why I picked this chart. I thought it was fun. It induced an LVO stroke So she had a large vessel occlusion it doesn't say what artery, caused a thrombectomy procedure to be done. And she still has residual effects from that stroke that included left-sided weakness and left facial nerve. And now she's weak on the left side. Interesting. Now, here's the thing I didn't tell you last session. When patients have strokes and they recover, can they stroke again in that same area or around that same area? And the answer is yes. Just like a heart attack. Can the patient who had an inferior wall MI 2 years ago have another area in the inferior wall? Can they have a heart attack again? The answer is yes. There's an area around the infarcted tissue that is kind of getting oxygen, but kind of not. That's called the penumbra. And that area can recover fully, sometimes not. And guess what, folks? That area can actually go on and have ischemia and infarct. Okay? We all know that ischemia leads to infarct if it's not treated. We all know that infarcted tissue dies. If that tissue is muscle, they have muscle necrosis. If that tissue is nerve tissue, the nerves die. And in a stroke, I didn't tell you this either, for every minute that a patient's having lack of oxygen to the area in their brain, they're losing 2 million nerve cells. 2 million brain cells every minute. That's why minute counts. Now, I lost a lot of brain cells when I had biochemistry. That's my stroke. That is the side. It's a sense of humor there. More on our case. That's pretty interesting history, isn't it? I thought that was good that they picked up on that. So she usually is independent with a walker, but her partner had to assist her this morning, this afternoon. She still has some residual effects. Facial droop is worse. And now she's got expressive dysphagia in the form of slurred speech. So she's slurring speech, just like an alcoholic would do. And don't be fooled, some alcoholics can have a stroke at the same time. So even though their BAL is 325, it still could be a stroke. That's ICT very liberally on alcoholics, especially if they've had trauma. I was feeling well until I went to the bathroom and found myself not able to get up. She was able to communicate that history to her partner before you got there. Interesting enough. Constipation in some of the reference. A good sentence because it gives the reader an indication that she was straining. Could that cause a ruptured aneurysm in the brain? Probably. That's possible. Skin is warm, pink and dry, GCS of 15, no respiratory distress. Fast ED score, they calculated at 3 out of 9, so right on the fence. Left arm drip, left-sided ataxia, left-sided facial droop with drooling, no eye deviation or denial or neglect. She's secured to a chair to assist while the box extricated. Remaining exams normal. She's a little diminished on the right lower lobe and middle lobe for whatever reason. That's a good observation. Could she have pneumonia? Could she have atelectasis? Could she have perhaps even a collapse of her lung? Maybe. There's no clue in the reader's narrative here whether or not the patient would have a pneumo. Because usually pneumo is absence of breath sounds on that side. Can a patient have a pneumo and can you still hear lung sounds? Unfortunately, that's true. But the stethoscope is not an accurate instrument, okay? And neither a sensitive one. Let's see. Oh, here's Dan and his ABD squirrel thing. We had a case the other day. This is an interesting trauma. 2 days before coming to the ER, this 56-year-old gentleman falls and he hits a ladder in his garage. The ladder is on the floor. He smacks his ribs. He didn't think too much about it, but it's hurting more and more and more. So he comes in rib pain. I'm okay. I'm not coughing. I'm not short of breath. Vitals sound fine. So in the workup, we do chest and rib X-ray, and sure enough, he's got a few fractured ribs there. But he has multiple fractured ribs. 2 of them fractured in 2 different places. By definition, that is a flail chest, right? And you and I both know that flails can go on to have tension and pneumothoraxes, right? And they can have pneumothorax and they can get complicated really fast. So needless to say, this guy went to CT, and guess who had a pneumo in the mediastinum, no less, because of a rib fracture. Isn't that weird? And there's no way none of us in this room would be able to diagnose that in the field. He didn't require a chest tube, but he only had like a 10 to 15% pneumo on that left side or right side here. Good point, by the way. So back to our case, 1 to 2 plus pedal edema. That might be because of a stroke and heart disease that she's had in the past. So let me dance over the vitals here. If I'm giving you too much boring information, that's the reason we're here, is to go over these. And by the way, at any time, if you have any feedback, good or bad or indifferent, or you want to email me with an anonymous name at the bottom and say I suck, you can do that too. Well, if you have my email address, it's easy. It's daniel.wilson@haywood.org. So here's a blood pressure 134/66, not bad. 61 and sinus rhythm, noectopy, respiratory rate is 16. She's 96% on room air. Skin's going to dry. Her sugar was down, but I think it was normal. Yeah, 115. Yeah, that's all fine. The lowest heart rate is 59. That's not bad. The CPK was 210. No, I'm just kidding. CPK in the field. Just seeing if you're awake. So, wisely so, Med Control is contacted. My good friend and colleague, Mike Shear, answered the radio. He was consulted and he gave the nod to transport the patient to UMass. 1, the patient had denser signs than she did in the past. Number 2, risk factors of open heart surgery and LBO after the open heart requiring thrombectomy. That was enough for Mike to say, yeah, you better go. Even though the fast ED was only 3, there's enough history there. So Mike and the medic put all the ducks in a row. That's what you need to do as a clinician in the field. Put all your facts together in the basket. What's the worst case outcome that this could be? Is this patient sufficient to go to Haywood and be taken care of by that Dr. Wilson over there? But can he handle it, or would Dr. Wilson freak if I took the patient there and they did better UMass? So, shortly enough, the patient gets to UMass. Stroke team's notified. They get her right to CT and a CT angiogram. And sure enough, this patient is found to have a right MCA thrombus. Pretty big, a lot of territory involved. That's why this patient was getting worse on the left side. Explains the speech, explains the left dense hemiparesis, and sure enough, they did a thrombectomy on this patient, and she did very, very well. Risk factors: CAD, COPD, hyperlipidemia, paroxysmal atrial fibrillation, even though she was on Eliquis, and diabetes mellitus too. All right. So she had a thrombus, not an embolism. The Eliquis was taking care of an embolic event, right? Blood clot from the atria, but still she formed a thrombus in the artery. Chances are, with all these risk factors, and even though I didn't look deep enough to see if she was on a statin to prevent hyperlipidemia, so even though we're treating all these risk factors, unfortunately, she can still go on and have disease. Is medicine perfect? The answer is no. So interesting case, huh? So everybody involved, the first responders and medics got this right. This patient's having a stroke. We did all we could, and we took her to the right place. Any questions on that? So that was truly a stroke. That wasn't a mimic. But you thought outside the box, and how do you? Remember, is it a seizure? Is it a stroke? Is it an infection? Is it trauma? Start thinking that they're very obvious. Yeah. Can a stroke actually be manifested if the patient's absolutely hysterical? If they're acutely psychotic, maybe? Can they actually, their anxiety be so bad, can it cause a stroke? Absolutely. Weird, huh? Can a migraine cause a stroke? It can look like a stroke, yes. You treat the migraine, the stroke goes away. Yeah, patients look at me like I've got two heads. I think this is a migraine. Are you sure? You look at me. Yeah, based on what you told me and the negative CT scan, I'm going to give you some medicine, IV and fluid in more than half an hour. Stroke symptoms go away, headache goes away, patients go back. Pretty cool. Not that I'm a hero, it's just once in a while I do hit the nail with the hammer. Oh, 73-year-old is all of a sudden confused and complaining of palpitations. That's something to keep in mind. The folks get there and let's see, down here, I think we got last time, I'll just keep reading. So the caregiver, the husband, says, and he says this very early in history, which I thought was interesting. Oh, she's only had one martini with lunch today. Now that's kind of a clue to me that she drinks a little bit more, because that's the first thing out of his mouth. And just to get it clear to you, she only had one drink today, which would imply that maybe she had a little bit more than usual. She denies drinking wine. I thought that was interesting that that's part of the narrative. Husband claims patient presented with slurred speech at noon, and you are responding at 16:45, it looks like. Notice the delay. The delay is not you. The delay is the family and the patient. How many times do we see that? That's why it's really good if any of you get called to schools, senior centers, Rotary Club, whatever it may be, to give a talk on stroke recognition, emphasize the importance of time. If they see anything neurologic, and tell the lay person about the FAST exam, if they see anything in the FAST that looks abnormal, 911. Don't second guess. Let us do the guessing for you because we're educated to do that. So enough of my preaching on that. Slurred speech at noon. This is now 16:45. Her behavior did not improve before calling EMS. Patient presents with extreme anxiety and worry. She's kind of over the top. She's stating over and over again that she has POTS, paroxysmal or positional orthostatic tachycardic syndrome. She dwells on this. I feel like my heart is racing. I'm going to burst out of my chest. She states her head is pounding, so she's got a headache maybe, and going to explode. This was quoted. Patient husband states that she has anxiety issues, but nothing close to the current presentation. I've never seen her act like this. So she's found lying in her bed on the second floor of her home, which means she can go up and down stairs, perhaps. She is only oriented to time and place, and events. She doesn't seem to know anything more than that. Pupils reactive polite, airways patent, respiratory rates rather rapid, hyperventilation maybe. No adventitious lung sounds of your auscultation. She's atraumatic, skin's fine, no diaphoresis, extreme anxiety with no short-term recollection. What part of the brain helps you with short-term recollection? Right up here, your cortices, right? So if I ask you, what did you have for supper tonight before you came, and you can't remember, that might be a problem, although maybe some of us don't know. So what did you have for breakfast? What was your favorite meal this week? Most of us can remember that. What was the last call you had before you came to M&M tonight? What's the last patient you saw that really had a head bleed? So those are things you can recall and remember. But this lady cannot remember anything recently. She repeats questions. Why are we here? What's going on? Where are you going? You know I have POTS. My head is pounding. My head is pounding. Where are we going? She repeated over and over again. Repetition is another syndrome of the anterior cerebellar syndrome, so keep that in mind. Also can be the speech area in an MCA lesion is affected. They can have repetitive speech there. Oh, this is interesting. She had COVID 3 weeks ago. Now, post-COVID caused stroke. I don't think all the cards are in yet, but for a general answer, you and I both know COVID is being blamed for everything. So why is the economy in the United States so bad? Well, it's COVID. You know, why does my tire go flat in my truck? Well, it's COVID. Everything's COVID. I was going to pass out when I was sitting upright, and the patient is repeating this POTS thing. Eventually, she calms down. Vital signs are done, and they look normal. Let me Let me dance over here. Let's see. Yeah, blood pressure is a little high. It's 158/82, 93, and regular. The respiratory rate is 30. Is the patient hyperventilating? Absolutely. What was that? That is 97. That's pretty cool. And she continues to show good heart rate. So this is not a tachycardic syndrome. This does not look like postural orthostatic tachycardic syndrome because her blood pressure is, if anything, is on the high side. That's really good. And she's very, very anxious hemodynamically. So that's pretty cool. Let's read on. Good story here. Okay, so vital signs look good. She is sitting up, cooperative a little bit, assisted to stand, gets on the cart there. Husband again states that she hasn't been drinking outside of one drink at noon. I just find that really intriguing. She has been complaining about a headache since last night. What's on your differential? Lady that drinks, did she fall down last night that no one knew about? Could this be an intracerebral hemorrhage? All people that drink that bump their head are obeyed until proven otherwise. Just a caveat. So, patient and husband are asked specifically about trauma. They deny any trauma or falls. Patient is not on a blood thinner. It's another important question to ask. If you guys ask that, put it in your narrative. It's very helpful. Has she self-medicated for the headache? Good question, because people still do take aspirin for headaches. Aspirin causes bleeding. No additional resources are needed. She gets on the ambulance cart, cooperative, 12 weeks done, non-diagnostic. She is reassured. Now, here's a beauty. She's in the truck. She goes unresponsive and maintains an airway. Eyes are moving around. They're 5 to 6 millimeters. Pupil sluggish. Right pupil non-reactive. Patient does not respond to heavy physical stimulus despite repeated attempts. 20 gauge IV started. She's getting fluid bolus, placed on oxygen. And then suddenly, after 3 minutes, she responds. Now, this is getting pretty interesting. That's why I picked this conclusion. What do you think? Could be seizure. Yes, yes. Alcohol in the history in the background. She's got this weird office maybe. Could be a seizure. Could she have bumped her head and has a seizure as a result of it? Absolutely. She's in and out. And you guys didn't do much. You didn't give her midazolam. You didn't give her Narcan. You didn't give her glucose. You didn't do anything. She's in, she's out. So it can't be hypoglycemia, right? You'd have to give her the dextrose to bring her out of that. Okay? So that's really intriguing. So now she's had an unresponsive episode and comes right out of it. I feel nauseous. I feel like she grabs her head. Oh, I feel like my head's going to pop. Again, your physical findings don't find anything. In all your wisdom, you guys decide to transport her to UMass. Good choice. Stroke entry is activated. This patient is worked up to the 9s. CT is negative. CT angiogram is negative. They do the golden workup with MRI, echocardiogram. Everything's coming back. And guess what her blood alcohol is?
220.
Yeah, closed. Yeah, it's well closed. It's 216. So earlier, remember, this was 16:45 in the afternoon. She started getting weird maybe at noon. So something tells me she was drinking most of the morning and it was much higher than that. So as she's coming down and withdrawing from alcohol, she had a alcoholic withdrawal seizure right in front of you. Isn't that cool? So this was probably an alcoholic thing. Her sluggishness and stroke-like symptoms was clearly alcohol intoxication, and that was the diagnosis at time of discharge. And they thought too that they thought this was withdrawal seizure. Pretty cool. Now, is there any way we would know that in the house? No, because you guys don't get blood alcohol, ice.
We just have to take the environment, empty alcohol bottles, because they don't always throw them
Yeah,
away.
that's right.
There's history.
So one could look around and see empty bottles. Man, am I thirsty? You might excuse me for a minute. You open up a refrigerator, case after case of Michelob. I only bought that because they're sponsoring the Olympics. So
How big the martini glass was.
Yeah, that martini glass could have been full. Kind of like, is it Applebee's? Applebee's or Chili's that gives you that big margarita glass? Okay, you guys have time for one more? I hope this is educational and fun. That's what I like. I like reviews that are educational, not punitive. Believe me, if I find anything that arbeit types of stuff, I would email the coordinator, training coordinator of your service and you personally, and just say, come on in, let's talk about this or whatever. So, and it's rare. Fortunately, knock on wood, I have some good medicine in too. So let me see. This is. Oh, 73. Okay. This is a 72-year-old male. You're called to the scene because of a head strike, it looks like. Yep, fell outside. He's at a party. Okay, fell outside. He's bleeding from the head. He's 73. Stop. 73, bleeding from the head, head strike. Worst case scenario. Head bleed, head trauma, right? Okay, you guys are thinking wisely. Think the worst, work backwards. He's bleeding from the head. It's one male. He's alert and oriented ×4, lying on the ground. Controlled bleeding noted to the right temporal area. So he scuffed his head here. Pupils equally reactive. Rapid assessment is negative for gross trauma outside of this. Laceration above right eye with bleeding controlled by bystander pressure. That's nice when the bystander helps out. Patient denies any numbness or tingling in his extremities. Upon speaking further with the patient, he is noted to be speaking utter nonsense. Great observation. In just a minute or two, this assessor has already figured out this is something wrong. Something's wrong. A, I've documented head trauma. B, I've documented abnormal speech. He's nonsense, ranting. He's ranting about stories with repetitive questioning. He's questioned as to whether he was joking or serious, but patient noted to be recounting events as if they were vivid memory. For example, I like the writer puts the example. Quote, Hitler did not die in 1945 because he killed him in 1955 at the age of 5. Quote unquote. Does that make any sense at all? Now, just as an aside, I'm a history buff, you guys, and there was not a lot of strong physical evidence that Hitler killed himself because no one really could prove where the body was. They supposedly buried it right away because Hitler was so narcissistic he didn't want the people to know that he killed himself. There was theorists that he went to South America and lived for several years, blah, blah, blah. So that's probably what this guy was related to. But anyway, doesn't make sense. No one on the scene is familiar with the patient. He's at a party. So a lot of people don't know him very well. Unable to ascertain what his baseline is. So transport to UMass initiated for probable head injury. Anticoagulation status unknown. Glad you asked. You didn't ask the patient. He didn't know. Partygoers don't know. So you put unknown. He does have a cabbage scar to his chest. Nice piece of observation. So assume blood thinner usage. Yeah, may or may not. Not all cabbage patients are anticoagulated, but it's a good point. C-collar is sized and applied. Oh, yeah, that's good too. Head trauma. Once in a blue moon, we'll see a head trauma patient walk in the triage, and then the nurse will walk the head trauma back to the room without putting a collar on. Yes, that does happen from time to time. We all know that that's erroneous because the patient cannot tell you if their neck is hurting, if their head is pounding, right? So, better safe than sorry. 18 to left forearm, blood glucose 198, vital signs, yep, heart rate 75, sinus, no non-ischemic EKG, blood pressure 173/78, 18 respiratory rate, 98% of room air. That's pretty good. Okay, no, it says, reader be advised not to pay any attention to the if you heard walk. No, just kidding. Just seeing if you're awake. So anyway, this patient gets transported to UMass rightfully so. During transport, no gross change to mental status or hemodynamic condition. Blood vital signs are continued. Great, kudos to you. I have an occasional nurse or two who will not repeat the vital signs during their entire stay in the emergency department. You and I all know how erroneous that is. If the patient presents with a fever and their temperature isn't retaken, and at discharge they still have a temperature of 102, really? Yeah. So just keep in mind to repeat your vital signs. Brought to CT, it goes right to CT from the ambulance bag. CT at UMass to rule out plate is done, and it is negative. UMass doctors do find that this patient is on a fixed band. Unfortunately, no bleed. They also do a nice golden workup, angiography, MRI, echocardiogram, blah, blah, blah. He goes up to the floor. He gets really weird at sundown at night. Guess what? This guy's got dementia. Yeah. With further neurological testing, it's found out that this guy's got some odd dementia. So maybe these weird statements is part of his underlying dementia and not brand new. So the head strike was just a red herring. He just bumped his head, scraped his head. That's all well and good. He had underlying dementia. And that will throw all of us off because you and I don't know. So can a dementia patient have a stroke? Yeah, that's right. Kind of wild. So there you have it. A nice little review. Obviously, you guys at M&M, I can't review every record that comes across my desk. I'd love to do that for you because we've got some great stories in our weird stuff. So what I'll do next time, I think we meet in September. But what we'll do then is, if you don't mind, we can review shock at that time, and in the meantime, I'll pull some good cases along the way. Some of the cases, if they're really intriguing or odd or unusual, I'll bring in. This one, I'd like to see if I can get images. These are 2 stroke patients that were life flighted from Athol ES, and both of them had LVOs, and they sent us the images, which I think would be really fun for all of us to see. The images of the stroke before and after thrombotic or thrombectomy, and you can see the arteries of that. Really cool stuff. So I'll work on that and see if I can get that in PowerPoint. That way I can share it with you, because the visuals are fun to see. That way it'll make it more interesting for you to treat a stroke patient, and then you can visualize just where we're going. Any questions on any of the cases, runs? If you guys have any runs you need me to review in front of M&M because they're good, they're bad, they're ugly, by all means let me know. You can guarantee that I will read them anonymously. I'm not going to put any of you in the hot plate in front of your peers. That's punitive and dangerous. Okay? We're here to learn, not to be punished. Okay? I appreciate what you did. Any questions?
Thanks, Doc.
You're welcome.
Make sure you sign the rosters up front if you haven't already. Those of you online, I have all the names that you guys put in. I have you on the rosters. You can see the chat as to where to email if you need a copy of the roster. And that'll be that. Thank you for joining us, and we'll see you next time, guys. Thank you.
Tomorrow.
Hey, Dr. Wilson.
Yeah.
Can I just get you a sentence real quick?
Oh, yeah.
Jen already knows,
This is
but I'm not until like
before.
9 or so.
I'm on speaker tomorrow night, so she'll
Yeah.
be there or she'll.
Oh, we didn't.
Okay. All right. Yeah. I let her know. She's told me to let you know.
You mess it up.
I can't when I'm taking.
Make sure, sign up before you take pictures of it.
Is the other one all
Yes,
signed?
do it. I wasn't crazy.
Yeah, I think so.
Yeah. Yeah, thanks for keeping me on. I want you guys to get focused. Oh. I'm really glad you guys gave me that call.
Yeah.
Wow, you're good. I just jinxed them.
What
So-
do you live in?
Oh, I'm gonna pay.
Oh, do we need both sides?
So
I just do it because.
Are you
Oh.
on- are you on-
Otherwise you don't need both sides.
I
Okay.
don't think so.
Friday?
Just 'cause